We're into the final run now, data development and improvement, and some updates from the HPO. And we're kicking off with Lorna Collins, Senior Statistician from the Healthcare Pricing Office, who has a double honours degree in maths or something bizarrely impressive like that. So well done, Lorna. Yeah. Okay, take us away there. Thank you.
Hello, everybody. I'm Lorna, and I'm going to bring us through the work we've been doing in Outpatients and ABF. The work that I'm going to display is work that's been done by colleagues of mine as well in the outpatient team. So we've Laura Metcalf and Audrey Allen, who are part of data analytics, and Joe Hunter in the IT team has been doing this work with us. So why are we bringing ABF into outpatients? And the reality is that it's one of the key objectives of Sláinte Care is to bring ABF and pricing and into the outpatient area. There's about 3.5 million outpatient appointments, 1 million are new and the balance are review, and about 500,000 DNAs. So that's a lot of attendances to actually not have very much information about. We do a very high level average cost of an outpatient attendance, and based on the latest specialty costing files we've got, it's about €220. But there's no complexity, there's no ABF modelling on that. It's a flat ABF, it's a flat costing. Currently very little information behind that data, and each hospital defines the directors, and therefore the information we have and comparability is very, very difficult. So if we want to bring ABF into outpatients, we need a lot of information, and we currently don't have it. We need to know the who, the what, the when, the where, and the why. Every person attending an outpatient appointment is consuming a resource, whether it's procedural or consultation, diagnostic or allied health. And to be able to fund the service, it's necessary to identify the activity, classify the activity, identify the costs of that activity, to ultimately allocate the appropriate funding for that activity. This is a national approach. We've worked with our colleagues in Access and Integration, with BIU Acute and with IPIMS, and we're working to define a minimum outpatient data set that meets the needs of all of us. So we'd capture once and use often. And in terms of data capture, there is no automated data capture for outpatients at present. So we're working with the OCIO and IIS to actually develop a capture for the IPIM system. The voluntary sites have their individual PAS systems, so we'll have to assess those as part of the implementation project we're undertaking. I'm also cognizant that NTPF have their own waiting list MDS, and we've been in talks with them to make sure that everything is in line with each other and that nobody's crossing paths. We've also presented to the IPIMS Change Review Group, the Healthcare Data Analytics Steering Group, the NCAGL Forum, the HSE Health App and the NPU to make sure that we're all aligned and we all know what each other is doing, and so there's no cross purposes. We did a pilot in the Midwest, in the 6 sites in the Midwest, and we went in there in about 2023, 2024. All outpatient clinics were identified across 6 sites. There was 1,000 outpatient clinics across all of those 6 hospitals. And we captured all the required characteristics for OCG and ABF. The mapping clinics were undertaken through educational sessions between ourselves and the HPO, and Julia Cotter, who was the scheduled care manager, and Fiona O'Rourke, who became our outpatient project lead. This mapping process allowed us to challenge and to test the classification, which was the main aim of the pilot. In the process that Fiona did of looking and reviewing each of the outpatient clinics, it actually came about a 35% decrease in the clinics on the system in the Midwest. They tidied up, they collated, and they removed unnecessary clinics that were there. There was a lot of learnings gained about the complexity of the outpatient process and the pathways that are there, and the knowledge gained allowed us to further develop the classification and then the creation of our online clinic register. HSE Midwest is currently in the process, as we speak, I think, of moving to IPIMS version 8. And once that's the case, the OCG will then sit on IPIMS version 8 in the Midwest. In terms of the outpatient minimum data set, we took the old OSPIP minimum data set of about 120, 130 variables, and we've condensed it down to 60 variables that meet the purpose of BIU and the HPO and Access and Integration. We're looking at things that describe the attendance, so the demographics, the classification, and the service, so things like source referral, reason for referral, whether it was a face-to-face or a virtual attendance, or whether it was a new or return. So we're working on capturing that information with the OCIO to develop a data capture process, and we're also working in terms of capturing the OCG on the IPIMS or the PAS data. How do you classify outpatient, which is about 3.5 million to 4 million attendances? You cannot ask hype coders to start coding an additional 3.5 on top of the near 2 million that they're currently doing at present. We look to the Australians, and they use a Tier 2 non-admitted classification, and it's a clinic-based classification. So instead of classifying 3.5 million attendances, you classify the clinic, and then every patient that attends that clinic gets that OCG. It's anticipated that the OCGs will be more effective in reflecting equal payment for equal output regardless of the service location. Within the OCG, there's 4 classes of care. There is procedural care, medical consultation, standalone diagnostic for outpatients, allied health, clinical nurse specialist and nurse practitioner care. And within that, we have 148 sitting within those 4 classes. It's the most feasible option for achieving the development of the classification for outpatients within a short amount of time, but also administratively and cost-wise in terms of implementing the classification. The process of mapping a clinic to an OCG, there's definitions of service and specific rule sets for each OCG. In the ideal world, it's done when the outpatient manager or systems analyst is setting up the clinic. It's one additional piece of information to be included as part of the setup. You start by looking at your clinic and what class it fits into, what's the specialty or the MDC, who's the provider of the service, so who is sitting opposite the patient, whether it's face-to-face or virtually, providing the actual care on that day. The definition of service, which explains the treatment of the clinic or the main provider of the OCG, and then the inclusions and exclusions give you that little bit of extra direction if there's any specificity to get to the correct OCG. The Outpatient Clinic Register, which was developed as part of the work through the pilot, is built by Joe Hunter in our IT team. It's an in-house product, so there's no licenses or vendor costs associated with it. And it's there to capture the 4 quadrants of information that we need for both OCG and for the ABF. So it's looking at the clinic characteristics. So what's the clinic descriptor, the PAS code, where is the location? We're looking at the classification, so the specialty and the OCG. We're looking at the clinic timetable. So how long is the clinic running for? What days of the week? How often? And we also have the ability to capture on-demand clinics. We're also then looking at the staff of the clinic. Who's the clinical governance of the clinic? And then who are the consultants or the shared carers that are working in the clinic? And we're using the CORU list for the shared carers as a feasibly small list. They're registered with CORU and it was set up on a statutory basis. The Outpatient Clinic Register looks as so, and it's got given different views so you can see your data. You can register new clinics, view all your clinics. You can look in and see what clinics are running today. And then you have your information, your documentation there to reference when you're looking at your data. In terms of capturing, in terms of the registration of the clinic dashboard or clinic register, it's literally a register with drop-down fields with a selection from pre-prescribed lists. So things like location and specialty. Input is needed for the timetable of what's actually happening. We've had to limit the timetable to a particular set of 4 or 5 weeks of particular days and times. I know that some clinics happen every 7th Wednesday or maybe 1 quarter or maybe every 6 months, and we have the on-demand button to capture that. And when we have the activity data, we'll be able to capture that date and see what in those clinics are actually happening. The Outpatient Clinic Register, then you can actually see all of your clinics that are there and you can export it out to have a look at what your data is there. To support the Outpatient Clinic Register, we're also building a Power BI dashboard. This is, again, we're doing this in-house in the HPO. This is a draft and it's in user acceptance testing in Midwest at present. I've built this in Power BI, and the reason being is that you're giving us so much information in terms of the clinics. I really want to give it back to you in a way that is usable and accessible and that you can analyse the data that you have. So these are very small, but the first slide is basically the register and a summary of the data that's there. So you can look in straight away, see your clinic, your OCG, the description, your specialty, but you can see what time slots there, how many consultants may be in it, or how many shared carers. The second slide is the clinic frequency. You have the ability there to drill down into the data to get right down into the granularity of the clinic register. There's filters all around of days of the week and time of the day and specialty and everything, so you can cross-section your data down into the data. The distribution tab is to get a visualisation of where your activity is actually happening, how long your clinics are running for, and what OCGs are driving your particular areas of your hospital. We then have information on the shared carers, so you can see where those staff are, where your physiotherapists, your dietitians, your OTs. We then also have a clinic time intelligence, So looking at that day of the week, where your clinic's happening, what times of the day are happening, or if there's gaps in the service that maybe you can add in clinics to different times. This clinic register will provide extensive information on clinics operationally in the system. And if you've better outpatient data, it will allow for better informed decision making, particularly if you're looking from that day case into outpatients and potentially outpatients into the community. And it will allow for more effective use of the services and hopefully better policy making. So we're two parallel pieces of work. We're doing the classification piece of work and we're doing the patient level data piece of work. For the classification, every outpatient clinic will need an OCG. This will ideally be set up when a clinic is being set up, but we're currently working on a process of capturing what's the current open stock of data. We will approve the OCG. It'll then sit on IPIM. So every patient attending an outpatient appointment is assigned an OCG based on the clinic that they attend. And the clinic register then will roll up to become a national outpatient clinic database, and the patient level data that we have will roll up to become an outpatient national data set, the same way that HYPE is a national outpatient data set for inpatients and day cases. So if you know what should be happening from your clinic register, and you know what actually happens from your attendance data, you have a full 360 view of your data, what's actually happening in the system. To that end, we ran a workshop back in November in 2024. It was a 2-day workshop and we had over 120 attendances from the hospitals, scheduled care systems analysts. And I want to thank the hospitals for allowing staff to attend that day. They were under considerable pressure at the time and we really appreciate it. We had key stakeholders there, Access and Integration, BIU and IPIMS. And a little bit of it was introducing who we are, because in the outpatient area, nobody really knew who HPO were or what ABF was. So it was this is what we are, this is what we do, and this is what we're trying to do in terms of outpatients. The ask of the workshop was that for all the hospitals to extract all outpatient clinics. So we want consultant-led and delivered, but we want all your AHP, ANP and CNS clinics as well, to get that full capacity of what's actually happening in outpatients. To support that process, we gave a template, an X-ray template, and for every variable we had a specified specification listed. There was SQL scripts that Audrey provided for IPIMS that we used for the pilot, and each site is different, but at least it was a starting point that people could build from to use for that data. The team then provided additional support through calls and teams with the sites that were seeking additional help, and we did provide an extension to support sites as the same time the work on the HSE Health app was underway, and it's the same people all the time that are being called. The outpatient clinic register to date, we have been loading the clinics into the clinic register since we received them. I have to thank Richie, who has been helping to support this process with Joe. As of yesterday afternoon, we had 38 hospitals loaded into the clinic register. That equates to just shy of 11,000 clinics loaded. So all your clinic types. For 38 hospitals alone, there's 11,000 clinics loaded. Laura undertook the data quality assurance analysis, so there were statistical tests and logical tests on the data that was provided, and the results were provided back to each site. To further the work on that, next Tuesday and Thursday, we're having a webinar for the hospitals on reintroducing the classification again and the background of it, but also the methodology of mapping the clinics to the OCG. It's going to be Zoom-based. I hopefully will be sending the registration closed last night. We have about 140 people registered so far, and I will be sending out the webinar links tomorrow afternoon, everything going well. It's important that at least one person attends from each site, so at least that knowledge can then be transferred on to their colleagues if need be. We will continue this conversation. We're not going to just send you off out into the wild to do this by yourselves. The OCG is becoming mandatory. It has to be part of all your new outpatient clinic setups, and it should be recorded on the outpatient clinic register. HYPE, we request that you register your inpatient day case wards. For outpatients, we need you to register your outpatient clinics. By the end of the summer, hopefully, the outpatient classification will be implemented across the system. And from that point on, hospitals and regions are now responsible for the mapping of all new outpatient clinics and the inclusion of the OCG. And for the outpatient data to be included in ABF and national reporting, the requirement is that the OCG is present. Once we run the webinars next week, in about 2 or 3 weeks later, we'll run another session where we can deal with any issues or concerns that people have in terms of the mapping or the OCG. And if there's any local queries, we have a mailbox. It's hpo.outpatients@hsc.ie, and you can send an email there. It's a monitored mailbox, and one of us will be able to get back to you. And finally, the next steps is that the HPO is undertaking a lot of this work, but we're doing it with our stakeholders. It's a HSC project. It's not a HPO project, and it's driven by Sláintecare. We want to collect once and use often, but with the consistency of a classification and a minimum data set. We're basically trying to create a HYPE-like outpatient system. HYPE has had decades worth of getting to where it is now, and you've seen from the presentations today how useful it is. Outpatients, we're starting on that process, and we're having to build it from the ground up. We're going to continue the development of the classification, starting next week with the webinars. The OCG will become mandatory for the setup of an outpatient clinic. We're working in parallel on the outpatient data in terms of data capture and processing and making sure that it's there for national reporting. But hopefully you can see the value of the data that we're going to collect, and that for future planning, for consistency and comparability, and also for sites to get credit for the work they're doing. Because without that granularity of data, you potentially won't get the credit for the work that you're doing. And finally, to finish, I actually really want to say a sincere thank you. We've been working with all of the sites since November, and I know that we are another ask on people who already have an awful lot to do. And I sincerely thank you for what you've done on behalf of myself and the team. The positivity and the enthusiasm, even though you're under huge pressure, you really can see the benefit of what we're doing, and you really want to be involved, and we really appreciate it. So thank you very much.
Lovely. Thank you, Lorna. Thank you very much. That's great.